Once again, welcome Professor Jasmina Primožić from University of Ljubljana.
So, thank you very much for your kind invitation, Professor Spal. I'm very glad to be here today mainly to discuss the transverse discrepancies. As he told you, I come from Slovenia, and Slovenia is very well known to Croatians because everybody crosses Slovenia to come to Croatia. And today we are actually going to talk about a cross, but not this specific cross, but we are going to talk about crossbite. So, you know, crossbite is a transverse discrepancy. It's mainly related to a constricted maxilla, to a constricted maxillary arch, and it can be either bilateral or unilateral. Its prevalence is very high. It ranges from 1 to 2% in developing countries to almost 25% in developed countries. Due to the known etiology, due to the constriction of the maxillary arch, the treatment choice is really straightforward. So we need to expand the maxillary arch. And after that, we get a correction and a widened maxillary arch. The best treatment timing appears to be if we perform this maxillary expansion before the pubertal growth spurt. So if we treat subjects in the prepubertal growth phase, usually we achieve mainly skeletal effects. If we treat them after puberty, we achieve mainly dental effects. But is it true? Well, skeletal effects are the widening of the mid-palatal suture, the buccal tipping of the palatal halves, but among dental alveolar effects we have buccal tipping of the teeth, as we discussed previously, and we have also a buccal translatory movement of the teeth, of the supporting teeth of the expander. Among the skeletal effects, nowadays we focus also on the widening of the nasal cavity and on the airway. The palatal sutures usually widen either in a parallel or triangular shape. There are studies showing us that this suture after expansion widens in a triangular shape with more widening in the anterior regions, while other CBTC studies demonstrated that this widening is parallel. We actually don't know for sure how it widens and in which patients how it widens. So it appears that everything is related to the mid-palatal suture and to the stadiums of the mid-palatal suture, which can be either infantile, when it's very wide and shallow, juvenile, when it becomes more wavy, and we have the adolescent, even more wavy stadium, and the adult stadium, usually with bony bridges. What is related to expansion is actually that during the infantile and juvenile stadium we have less interdigitation of the suture, so we need smaller forces to expand, while in the adult patient we have more interdigitation, so we need very high forces to expand. The second thing why it should be better to expand during the prepubertal growth phase is work. You have batteries? Yes?
Yeah. Okay.
Is because we have more cellular activity during the prepubertal phases or stages of the suture, and because of this greater cellular activity, you get faster and better bone remodeling and bone growth at the level of the suture. And this is a slide, as you can see, from the Alpe Adria 2015, so it's almost 4 years ago, and was one of my conclusion slides at that congress. And you can see that you have a list of positive things in green in the prepubertal and pubertal and post-pubertal period related to expansion of the maxilla. And if you can see by eye that the list in green is has much more points during the prepubertal growth phase. So we achieve more skeletal effects during the prepubertal growth phase, less dental alveolar effects, we can use lower forces, we correct facial asymmetry, but on the list, on the pubertal and post-pubertal phase, the only positive thing appears to be that we achieve more stable results. But is it still the truth? Well, today my lecture is going to focus on the red points on the list. So we are going to discuss if it's true that during the prepubertal treatment, this treatment is really less stable, and we are going to discuss if we really, during the pubertal and post-pubertal expansion, achieve less skeletal effects, more dental alveolar effects, if we really need higher forces, and if we really do not correct facial asymmetry. So let's focus first on the stability if we treat in the prepubertal growth phase. In the literature, we know that if we treat posterior crossbites, especially the functional ones, during the prepubertal growth phase, we have larger percentages of relapse. Actually, the numbers are really different from different studies, ranging from 51% of stability, which means that either you have the same chance of being stable or not stable, to 100%. And it appears that this stability, it is not related to the appliance we use. Either we use a quad helix, a bonded expansion plate, and removable expansion plate. This does not relate to the stability.
By expansion plate, you mean Hyrax, but bonded type Hyrax?
No, by expansion plate, I mean the removable one, which nowadays it's not really used anymore.
Okay.
But studies that were performed earlier reported that we can have also 100% stability after the use of this kind of plates. So, but we are going to discuss later on why we don't use these expansion plates anymore. So instead of the appliance, maybe its stability, it's maybe related to the protocol of expansion that we use. Usually with expansion plates, we use more slow expansion protocols, or maybe a quad helix is also more related to a slow expansion protocol, while rapid expansion expanders that are bonded on the teeth are more related to rapid expansion protocols. Basically, a slow expansion protocol means that you need to activate your screw by 0.5 millimeters per week, while for a rapid expansion protocol, you need to activate it at least 0.2 to 0.5 millimeters per day, at least. And by doing so, you achieve much higher forces with rapid expansion than with slow expansion, but because of these higher forces, you get more microfractures of the suture. While with slow expansion, it appears that you still have tissue integrity because the forces are lower and the expansion protocol is slower. With slow expansion, we usually achieve a little bit less skeletal effects than with rapid expansion. And regarding stability, it has been proposed that for slow expansion, because you maintain all this tissue integrity, you can have a retention protocol of only 3 months. While for the rapid expansion, you can have from 3 to 6 months retention periods of you can choose. But is this true? Actually, we know that after rapid expansion, we get more relapse. A recent study aimed to assess the levels of the cytokines in the gingival clavicle fluid during rapid and palatal expansion and after it. And after it, they found out that this level at the tension side of the supporting teeth were still significantly higher, meaning that there is still some bone remodeling and bone activity at that site, which probably, if, this is why if we stop retention at 3 months and there is still something going on there, probably this is the way how relapse occurs. So based on this study, we should prolong retention and follow up and prolong the retention protocol for more than 3 months. Another systematic review that aimed to assess the retention protocols for fixed and removable appliances concluded that 6 months appears to be enough to get a completely stable result. However, we conducted a study in collaboration with the University of Trieste and Naples, and in this study we aim to assess the activity of the alkaline phosphatase, which is again a marker of bone metabolism, and we collected this enzyme at the level of the supporting tooth and at the level of the contour tooth, which was in the lower arch of the same patient. And as you can see, the activity at baseline was similar among both teeth, while in the 3 months after expansion and 6 months after expansion, the activity was still significantly higher in the supporting tooth than in the control tooth. So it seems that something is going on still at the 6 months follow-up, when actually we are finishing usually our retention protocol. And based on these results, we somehow decided that maybe 6 months it's not enough. We need to prolong our retention. So, when we are talking about treatment in the prepubertal growth period, we need maxillary expansion, we need to perform a hypercorrection with the palatal cusps of the upper teeth touching the buccal cusps of the lower teeth, because we know that there is always at least a dental relapse, and we should perform a retention protocol that should be longer. We first retain this appliance that was used for expansion for at least 6 months in the mouth, bonded in the mouth. So we usually expand for, depends on the child and on the transverse discrepancy, we expand for 3 weeks to up to 1 month, and then up to 6 months we leave this appliance in place.
So
After that,
for 8 months.
for 6 months.
6 months. Okay.
Yes. After that, it depends on the crossbite. So if you have a bilateral crossbite or a simple unilateral crossbite, which means that you have crossbite on one side but you don't see any midline deviation, and this crossbite is usually related either to a unilaterally constricted maxilla or either to tooth tipping, well, in this case, a good option is a transpalatal bar. You can see that on this transpalatal bar we have also an acrylic cup for the tongue to stimulate the tongue posture.
Is it rolling?
This one, no.
No.
This is fixed. And, but it has a small hole in it for the child to look for the hole. So for these two crossbites, it's quite an easy and straightforward retention, and usually for these two the stability is almost 100%. The great problems comes with the unilateral functional crossbite, which are actually due to a bilaterally constricted maxilla, which leads to a lateral mandibular shift. And you can distinguish these two by looking at the midline deviation, which should be in the unilateral functional at least 2 millimeters, And obviously this unilateral functional crossbite is associated with also a chin deviation and facial asymmetry. And in these cases, usually a musculatory impairment persists after we have expanded the maxilla. Usually when we expand, the muscles do not resolve and still slide the mandible to the side that used to be posterior in crossbite. So in these cases, we usually perform our retention with a Frankel appliance. In these cases, the Frankel appliance has mainly two mechanisms which work for retention. The first one are the buccal shields that prevent sliding of the mandible, so somehow center the mandible in occlusion. The second is the obvious and typical mechanism of working of the Frankel appliance is to achieve more space for the normal growth of the maxilla, and similarly for the labial pads. So for the prepubertal growth period, actually the result is not less stable, but we can increase stability by increasing our retention protocol, by prolonging our retention protocol and using proper appliances.
For how long do you leave Frankel and this transpalatal?
The transpalatal arch usually for 1 year, and it doesn't bother the patient. Usually they get easily used to it, and I usually mount it, as you could see, on the primary molars, not on the permanent molars. Then for the Frankel, the better this. Then for the Frankel appliance, it depends. It's at least 6 months, but then I look always how the patient slides and how the patient bites. If I feel that there is still a sliding of the mandible, I prolong it. But they don't wear it more than 1 year, or because I think children are not able to wear appliances for such long period. I think nobody is able.
So up to 1 year, not more than a year.
Yes. You will never wear glasses if you can't see, just for fun. Not more than 1 year.
Maybe it works now.
Yes, okay, let's try. So now we are going to look at the second red points on the pubertal and post-pubertal list. So we are going to look if there are really less skeletal effects, more dental alveolar effects, and so on. So with expansion performed at the pubertal or post-pubertal growth phase, it appears that we mainly achieve dental alveolar effects. Therefore, buccal tipping and buccal translatory movement. Due to the interdigitation of the mid-palatal suture, we need higher forces to disrupt this suture. And these higher and heavy orthodontic forces usually create hyalinization at the supporting teeth, at the buccal parts of the periodontium of supporting teeth, and this causes somehow a sterile necrosis, which leads to either a reduced buccal bone thickness, a marginal bone loss, buccal gingival recession obviously after that, and also root resorption. There are studies showing us that on the supporting teeth of expanders, we have on the buccal parts small resorptive lacunae, which are actually consequences of these expanders. Moreover, recent CBCT studies found also that there is a volume loss. They aim to assess the volume of the roots, and they found out that there is a volume loss of the roots after expansion. There is also a shortening of the roots and many resorptive lacunae on the roots when you use tooth-borne appliances. Therefore, appliances which support on teeth. So it appears based on this research, that it's better to use the primary teeth to expand. This is a research by Ugolini and co-workers who aim to assess if we gain similar results if we expand in the pubertal growth phase either on primary teeth or permanent molars. So if we use primary teeth as supporting teeth, do we get similar effect than when we use permanent molars as supporting teeth? And actually they found out that the skeletal effects are almost equal in both groups. So either you expand on primary teeth or permanent teeth, you get similar skeletal effects, but you get less dental alveolar effects, obviously, if you expand on primary molars. So this is another point, although you are in the mixed dentition phase, to use still the primary molars, primary teeth, for supporting teeth for your appliances. But it's not always possible, obviously, in the mixed dentition, especially in the late mixed dentition, to use primary teeth. You need to check on your OPG if these primary molars are going to be good supporting teeth. And you check this by looking at how long is the root. And the least possible ratio is 1:1. So if the root to crown ratio is less than 1:1, so the root is restored, you should not place your appliance on this teeth. So what then? What shall we do then? We have any options? Yes. Nowadays we have another option. Instead of using teeth, we can use TETs. We can use temporary anchorage devices. And we can use two kinds of appliances for now. Either the two bone-borne appliances, which are hybrid appliances that are placed on TETs and teeth, and the bone-borne appliances, which are mainly placed on TETs. These appliances can be placed only on two TETs, but it appears that if you place only two TETs and a screw here, you get a widening only in the front and only a diastema, but not a true skeletal effect. Then you have some tandem, maybe you heard, some tandem appliances where you put two in the front and two more backwards and the screws in between and so on. So sky is the limit in that, or your fantasy is the limit in this kind of appliances. But are these, placing a mini screw, it is somehow an invasive procedure. You need anesthesia, you can have some complications, and believe me, when you have very narrow pallets, it's a hell placing them, and it's a hell constructing the appliance. And you will see all the lecturers that are lecturing about mini screws are always showing those white pallets. So for distalization, I would say it's very easy. But for expansion, and actually you decide for this kind of appliances when you really need expansion, it's a hell of a job, at least for me, to do it. It's not easy. So this is why I always question myself, is it worth it? Is it better to use this kind of appliances than use the tube-borne appliances? We have some recent answers from the literature. One study performed by Lagravère and co-workers in 2010 aimed to assess the expansion effects among 13 to 14 years old adolescents of rapid maxillary expansion, and actually he concluded that the effects are completely equal. Either you use a tooth-borne or a bone-borne appliance. So based on this study, I will decide, okay, I'm not going for it, because it's nonsense putting mini screws and expand if it does not work or if it works similarly as the tube-borne appliance. But then we have other studies, for example, the study by Lin and co-workers, who concluded that bone-borne expanders produce greater skeletal effects and fewer dental-alveolar side effects compared to tube-borne appliances. But as you can see, the age group of Lagravère was 13 to 14 years, while in the study by Lin and co-workers, the age group was a little bit older.
Much older.
Yeah, well, a few years. A few years is nothing now at your age.
Yeah, in this age, but in this age.
Okay, so it appears that maybe the results are different because of that. But last year, Zellen and Kotza concluded that actually, and it was again a CBCT study, that bone-borne expanders produce 1.5 to almost 3 times greater skeletal effects and without any dental-alveolar side effects compared to the tube-borne appliances. And you see they had a very similar age group as Lagravère had. So where is the truth now? Who do we believe to? And they had a very similar protocol in the study, all measured on CBCTs. So now what? Yes?
How many patients have the study included?
I'm going to tell you. They were really small. This is one of the problems, really small samples, but we are getting there. So maybe the answer could be somehow retrieved from the study of Angelieri and co-workers. And maybe is still everything about the suture. Angelieri and co-workers developed a method of assessing the suture maturation, the palatal suture maturation on CBCTs, and divided the suture maturation into 6 stages, ranging from stage A, where the suture is shallow and so on. I'm not going into detail because it's a rather complex method. And recently also in the Angle Orthodontics, they published actually the diagnostic accuracy and reliability of this method was tested, and it's not excellent, let's say. You need to learn the method. So they actually found out that the first 2, if you see on a CBCT, the first 2 stages of the suture maturation, these patients would benefit from tube-borne appliances. You will get skeletal effects also using tube-borne appliances. If you see stage D or E, you need a surgically assisted palatal expansion. When you see stage C, these are the patients that would benefit from TETs. But as you can see, they grouped the patients also according to age. And if we look here at the age group of the subjects that were included in the 2 previous studies that we talk about, you can see that there is a huge variation in the maturity of the suture during this age, in this age group. You can see that many are still in group B, which benefit from tube-borne appliances, while some are in group C that would benefit from TETs. And due to the small sample size in the studies, it is possible that actually in the study of Lagravère and co-workers, mainly there were subjects of this maturity stage. While in the other one, it's possible, and this always happens when you have very small sample size, that the subjects were mainly, not all, but mainly in this stage. So this...
They have like female and male with 24 before.
Yes, yeah. So this is why the sample size you should always look at sample size and everything related to methodology to actually understand the results and conclusions of the study. And obviously the limitations of any study, because every study has its limitations. There is no perfect study. This year, a meta-analysis and systematic review was published in Progress of Orthodontics regarding the use and the effects of tube-borne appliances and tube-borne bone-borne appliances and only tube-borne appliances, and they concluded that when they compared bone-borne and tube-borne appliances, there is a greater skeletal effect with bone-borne appliances, but equal effect regarding buccal tooth tipping, which is somehow surprising, equal effect on the nasal cavity width, and equal effect on root resorption, which is a little bit strange, but it seems that also with bone-borne appliances you achieve root resorption, or either they did not diagnose or misdiagnosed root resorption with tube-borne appliances. When they compared the two bone-borne appliances, so the hybrid appliances with only two bone appliances, they found out that there is less buccal tooth tipping of premolars with tooth-to-bone appliances, with the hybrid appliances. There is greater nasal cavity width when you use the hybrid appliances, but you get equal skeletal effect, equal molar inclination, obviously because also the tooth-borne appliances are on the first permanent molars, and actually it hurts always patients and equally. Either you used mini screws or not. But there is a but, probably why also this was published in Progress in Orthodontics. Although they included only RCTs, which are the best quality possible of clinical trials, there were only a few studies included, and with low scientific quality and low sample sizes. This is why we cannot really withdraw some clinical conclusions based on this meta-analysis. Okay, we have some guides, what's the trend, but we cannot have some tough conclusions based on this meta-analysis. And as a usual statement after all, at the end of all systematic reviews and meta-analysis, further research is needed, well designed, and so on. This is a typical conclusion of all systematic reviews and meta-analysis. So we are back to the lists. The only red point in the prepubertal was the last stable, but we can see that the many red points in the pubertal and post-pubertal are not really much more red points. We get skeletal effects, but we need to use another methodology, another technique. We have higher forces, but what about facial asymmetry? Well, facial asymmetry is related mainly to unilateral functional crossbite, not to the bilateral and not to the unilateral crossbite, the simple one. And this facial asymmetry is not only related on what we see on the face, but it's also what it is beneath it. It can be related to the thickness of the masseter muscles, for example. Kiliaridis and co-workers found out that children with unilateral posterior crossbite had significantly thinner masseter muscles, assessed by ultrasonographic methodology, on the side of the crossbite compared to the normal side. And after treatment, you can see that this resolves. And you can see that these children were quite old, were almost at the pubertal edge. So it means that if you treat in the pubertal, no matter what, this asymmetry in the thickness is going to resolve. Another study by Alacron and co-workers aimed to assess why this thickness difference was present, and he postulated or hypothesized that maybe it is related to the activity, electromyographic activity of the masticatory muscles. And he assessed two groups, one with normal occlusion and one with posterior crossbite, I think on the right side, yes. And he concluded that there were actually differences in the electromyographic activity of the posterior temporalis muscles and also on the masseter muscles, where there was less activity of the masseter muscle on the crossbite side and more activity on the normal side. And maybe this smaller activity on the crossbite side is also related to a thinner masseter muscle on that crossbite side. Arat and co-workers aimed furthermore to assess what are the changes of the electromyographic activity after rapid maxillary expansion. And they concluded that this activity immediately after rapid maxillary expansion decreased, and after the retention period increased to somehow normal levels. So the point of this study was that after you have expanded, you need to care about also how these muscles function, because maybe the activity of these muscles are related to relapse. And the low activity of the masseter muscles, especially in crossbite subjects, appears also to be related to a lower bite force. Sorensen and co-workers assessed the bite force of crossbite subjects in comparison to normal controls, and actually the bite force in crossbite subjects, no matter which side was, either on the crossbite side or non-crossbite side, was significantly lower in comparison to normal controls. And finally, a study was performed also, actually in this study they also checked for symptoms of the TMD, and surprisingly no significant differences were seen between the crossbite group and control group regarding pain, regarding jaw mobility, regarding clicking and so on. The only difference was again in the elevators of the mandible. So there were a palpatory tenderness and a difference between the two groups, with a greater palpatory tenderness frequency in the group with crossbite. So this was the only difference between the two groups. And finally, I need to show, I deleted all my studies from the presentation because I know somebody attended, so I need to change everything because of that. And finally, I included the only study of me, I think, here in this presentation regarding the degree of facial asymmetry. In this study, we aim to assess how facial asymmetry changes during growth and development if we have untreated crossbites. In fact, we examined facial asymmetry among children in the primary dentition, in the early mixed dentition, and in the late mixed dentition. And we look at the asymmetry of the face. We did it on three-dimensional facial scans. We usually produce some color deviation maps, but I'm not going to bother you with details. What is actually important is that the facial asymmetry in all three groups, all three developmental dentition phases, was significantly greater in the crossbite group, in red color, than in the normal controls. And this asymmetry was not different for the forehead, but it was different for the maxillary part. And please note that in the primary dentition, we don't have any significant asymmetry in the maxillary part in patients with posterior crossbite, while this asymmetry becomes significantly relevant in the transition from the primary to the mixed dentition phase. So it appears for correcting facial asymmetry, it appears important to treat them early. Similarly for the lower part, this was obviously due to the mandibular shift of all included subjects, significantly greater in all three dentition phases. So based on these results, we are more positive to treat specifically unilateral functional crossbites at a very early developmental phase. So in the primary dentition, if possible. We also performed another study when we compared the asymmetry if we treat them in the primary or early mixed, and actually we solved the asymmetry also if we treat them in the early mixed. But these results, remember, relate only to the unilateral functional crossbite. These are not related to the simple unilateral or bilateral crossbites. We have more time with those two malocclusions now.
Can I ask you the slide before?
Yes.
So, if we compare now these graphs, it is obvious that the effect size in the late mixed dentition is less than the effect size in primary and early mixed dentition. Can you comment it? How come in late mixed dentition, does it compensate by itself, or what?
Yes, probably there is a, this is actually strange. Maybe, first of all, it is not, this was a cross-sectional study, so maybe I was not so...
No, I know that it was a cross-sectional. But if not treated, there is some longitudinality that you can...
Yes, you would think that this would increase, but maybe the subjects were, the variability in between the subjects was so higher that you cannot see that coming. That's possible. Another thing is that in the primary you can have some masking of the soft tissue, of the fat tissue, but it's, and in the literature you have also some reports of self-correcting, also of the functional ones.
In late mixed dentition.
Late mixed dentition, so actually in the late mixed dentition and permanent dentition. You have, I have a few slides later on regarding self-correction that when thinking about it, maybe we should wait. But I'm following now this self-correction. The problem is that what happens at the beginning, when you are in the primary dentition, you have a functional asymmetry, which is related to the functional shift. And this functional asymmetry leads to different positions of the condyles. On the crossbite side, you have the condyle more upward, backward, and laterally. On the contralateral side, you have your condyle positioned more downward, forward, and medially. And this continuous different position leads to asymmetric growth. And this asymmetric growth, as you know, the growth of the mandible is the highest during puberty. So if we treat before probably the pubertal growth peak, maybe we are not getting skeletal asymmetry. If we still have this position during the pubertal growth peak, we are going to have asymmetric growth, and because of that, also skeletal asymmetry. But sometimes, also with this kind of asymmetry, which is skeletal, we have this kind of occlusion. So almost normal occlusion, and these are actually the most difficult cases to treat.
With the contofocus plate, yeah.
And as I said previously, studies, one an older one from 92 and one more recent, report that there is self-correction of posterior crossbite. And this again questions us if shall we treat them or shall we wait? I don't know the answer. I just know that in some patients when you see this is not self-correction.
Self-correction.
It's only occlusal adaptation. But some really resolve completely by themselves. So what shall we do? I usually, if I have a functional crossbite and the patient is compliant, I treat them as soon as possible in order to prevent all different activities of the muscles and so on. If you have maybe only a unilateral simple crossbite, maybe we should wait. Because if it does not resolve, we still have appliances, we still have tats, and we can use them. Sometimes it's not such a hurry to do it immediately, although I prefer to treat them early.
But in your study, you were referring to facial asymmetry, not to occlusal adaptation as a measure. Yeah,
that's right.
Because he has occlusal adaptation, but he's still facially asymmetric.
Completely asymmetric. In those studies, they focused mainly on occlusion.
Yeah.
They looked at occlusion. And this is again what we were talking previously. It depends what you look at. And if you look only at a specific trait, then maybe you are going to miss something. So you need to have a general picture and decide for each patient individually. So let's color that in green. We have, after treatment during the prepubertal phase, a stable result, but we need to prolong retention. But we should give ourselves also some limits. I'm not the kind of orthodontics that makes wear patients Frankel appliances for 8 years. I'm not that kind of orthodontics. Although I come from a school that used to do that.
Functionally oriented.
Yes, yes. I prefer to correct first morphology and then function. Although I was taught completely the reverse. That's true.
Yeah.
But you should always learn from many people who think in different ways. Then on the pubertal, post-pubertal list, we saw that we can have skeletal effects. We don't have really so much dental-alveolar effects if we treat them during the pubertal and post-pubertal phase. So actually, if we use that, we can wait. Indeed, we have higher forces, so less biologic expansion. And regarding facial asymmetry, well, in some cases probably it resolves per se, in some cases it develops into a skeletal asymmetry. And because of that, and we don't have a discriminate factor to know which one are going to resolve and which one not, I would suggest to treat the ones that appear with facial asymmetry as early as possible. And treatment at puberty and post-pubertal is always more stable. So the treatment protocol that I usually use is expand for the bilateral crossbite and the unilateral simple crossbite is expansion of the maxilla. I prefer to use this kind of bonded appliances on the primary teeth. I always use a primary teeth as supporting teeth. After that, I have a retention period with the same appliance for up to 6 months, and then I switch to another appliance because it's more patient-friendly. It's quite difficult for the patient to wear this, and if the 6 are erupting, with this you have to deal with some vertical problems. So I remove this one and then use usually a transpalatal bar. Or either, if the patient doesn't want, or it's not compliant, or needs to wait in the list, we now have some good other options if we get patients at later developmental stages without any really panic. For the functional one, as I said, I use the same appliance for expansion. For the functional, it's even better to use this one because somehow you disarticulate the mandible. And then, again, up to 6 months, I leave this appliance in place and then I use the Frankel appliance. So, a lecture is always a two-way road, so now I'm ready for your questions, if there are any. But I'm glad that we discussed something just in between. Yes?
For the mini screws, what is the lower age you can place them?
I would say that I saw that people are placing also mini screws in the early mixed dentition. I would never do that because with 2 bone appliances on ease you achieve the same results, and for me this is not ethical to do. With the new protocols, when you can plan and print a splint with guides to place the mini screws, actually you mean probably if there is a canine or something that might bother you, well, you don't have much more difficulties. You check, but you have to do a CBCT. You check on the CBCT, you do your guides of mini screw placement and then transfer it to the mouth. If the only limit, I think, is it's not an age limit or dentition limit, it's where the teeth are placed and how you are going to place the mini screw. So I would not say that there is an age limit, but you need, I think, still to think about ethics. That would be for me the age limit when not to place it. I would never put it in a child in the primary dentition, never. Never, for at least this year, maybe next year, we will see. No, things change.
So you're coming for the next summer school also?
No. Then I need to redo everything. No.
And also shows one study at the beginning with the resorption, with the parameters from the gingival fluid are shown from the sulcus fluid.
Yeah.
So the standard deviation, I didn't see the figures, I didn't memorize, but one standard deviation was 15. Do you think it's too high because in the
difference
upper
was
molars it's like 50 and the lower is like 32. So when you have standard deviation that is 15, it is like 47. So it's very near
to the one. Yes,
and they concluded something. So they must have at least one sample that was like
outlier.
went out there.
Yes,
there.
I agree with you.
Yes.
Yes.
So
and this
maybe
is why
it's better. Why? Just thinking. Why they took the samples from the lower molar? They could retrieve the sample from that molar at the beginning of the therapy. Why they should? It didn't have to be the split mouth.
I know. Use the same subject. Yeah, I agree with that. Sometimes you can use also the same subjects at baseline as a control for the next measurements. Yes, you're right. I was not involved in the protocol, so I don't really know why I decided. But usually in protocols, you know, after you have performed the study, you see the limitations and what could you have done. That's the problem. So, and as I said, no study is perfect. So, I don't know. Yes, to think about it, you can use also the same tooth at the beginning, before placement. But there were some other issues related to that study. It was not easy to perform because it was needed to achieve a very good hygiene. You know, all this activity of the cytokines and enzymes are related to the period status and so on, and are really also individual independent. And this is probably why also there is a huge standard deviation. And whatever you do in a clinical setting, whatever study is so individual independent, and this is maybe the most difficult thing when you do research in orthodontics, because no subject is alike. So today we discussed previously 3 subjects. You are not going to get another similar subjects in your career, the same. No way. So, and it's similar in research. Either you do research on rats, when you can get very similar subjects, but on humans, it's almost impossible to do it in orthodontics, I think. You try to do a homogeneous group, but it's almost impossible to get it. And this is why you get always very huge standard deviations and very shallow conclusions, I would say.
It's a quality control. Does anyone need a pen? Can I ask you something? That's something that I always ask you.
No.
So I've seen in Slovenia, in Ljubljana, that some of clinicians, after rapid maxillary expansion, they perform transpalatal arch and then also Frankel appliance.
I'm glad that you did not say the name. It's mainly related to the lab. Because I usually achieve that the Frankel appliance is constructed in 1 week, while others do not achieve that.
Yeah.
But I don't see, I think it's somehow over-treatment. You know, in 1 week you change the appliance, and you give the patient 2 appliances. Maybe it has some sense to have more stability of the transverse width, but again, then you need to expand the transpalatal bar, otherwise you are blocking normal maxillary growth, which you are not using the Frankel.
Good point.
You know?
Yeah.
So you have some more management during the post-retention period if you use the transpalatal bar, or even some use it in combination with the Frankel appliance, but I think if you expand enough, if you do hypercorrection, you do not get relapse.
So in Croatia, maybe 10 years ago, even 10 years ago, a basic protocol for mixed dentition for unilateral crossbite was the Schwarz plate.
Yeah. When I started my postgraduate, which was also more than 10 years
Can you comment
ago,
on that?
Yes. From studies, you can see that the Schwarz appliance actually also works. And there were some studies by Petran and co-workers who also demonstrated that you get some equal effects if you use the Schwarz appliance or the pot calyx.
At what age?
It was a later age. It was around 8, I think, 8, 9. Yes, in the mixed dentition. So it appears that it corrects crossbite. But again, all these studies did not specify which kind of crossbites were treated. So again, I'm saying that if you have a mainly bilateral crossbite or a unilateral, you may be due to tooth tipping, the Schwarz appliance will work for sure. If you need just to tip back the teeth. So in some cases, it works. In Slovenia, when I did my postgraduate, we also used the Schwarz appliance, but it was a step forward. We cemented the Schwarz appliance. And can you imagine what was underneath after we removed it? It was irritation, not so bad. I expected worse things.
Flora and fauna.
Yes, yes, but I expected worse things. But at least we had a fixed something. So things are evolving. This is why you need always to follow up literature and colleagues maybe and discuss. And maybe you learn something from somebody else, then combine it, and then you get your own protocol. You see what works in your hands. Maybe something that I do, it's not suitable for you. Or maybe something you do fits perfectly and works perfectly in your hands, but not in mine because I can't use it. It's completely possible.
Or the technician is to be blamed.
You said that, you see, you are filming. No, but yeah, the technician is important, has a role. We are now switching very much into digital. I'm having printed my appliances now, and as you know, in our former country, they used to say that Slovenians do it better, but actually Italians do it better. We are not so able to do it digitally for now, but I'm working on that. The technician group, it's the technician's fault. No, this is not a joke, it's really. When you have a clinic, you have to develop yourself, the clinic, the clinical part, but also the technical part. Otherwise, you can't do anything.
Okay, thank you.
Photo will take place
Yeah. Možda ona slika gdje se maksila širi, ono milje koje je izgledalo. To je izgledalo super. Wonderful. Yeah.
Hoćeš
To.
kaj boš?
To hoću.